Good afternoon, everyone. My name is Rajesh. I'm a student nurse educator at UniSA, and so part of that my course is to prepare education session and submit to the unit. So I have taken approval from unit manager here on the board, so that I can prepare an education session for the staff and then can educate the staff as well. So I'm taking this opportunity as in terms of teaching and as well as for educational purposes for myself. So first of all, I'm going to show the consent form, which because this whole session will be filming and I have to submit the YouTube video. So because you will be in that video, so I have to take a consent from every one of you, and so that consent I will be submitted to uni because that's something is illegal, and it will be confidential, and your names will be there, my name will be there, and my lecturer can only see that. I have just given the consent form, and thank you for signing that and giving approval. I can ensure that this will be confidential session, and all the if you want, you can show your faces, but if you think that you need to keep mask, you can keep the mask. So let's start. First of all, I will be distributing you some handouts for attendance and for session plan. So that's for you to get some more information about the session so that you understand what we're doing here on the board. So let me keep this attendance sheet. So there will be one attendance sheet. There will be another signing sheet about the session. And there will be a lesson plan. It's for you, for students, so that you know what topic I'm going to teach you, and how long that will be, and what information it will be giving to you. So I just distribute you. Please take that. Thanks for that. Thank you for giving consent for the session. And so this is, if you can distribute, please. So this is education session information. It tells you about objective of the course. It also tells you about intended learning outcome of the course. So it gives you whole information about the session. I do have my own teaching session plan, and that's give me information, will keep me on track what intended learning outcomes I need to go through and what we achieving after the course, after the session, whole session. So before we start, I'm going to distribute this pre-quiz as well for all of you, so that you know that what you learned before starting the course, and there will be a quiz at the end of the session, so that you can compare yourself that you have learned from the education session. So I just distribute these around, so if you can please complete this quiz as you get time. And so this will be the session quiz, and living with you. And this will be attendance sheet. I have to submit to the board that you have taken education session. If you can please move that around. So you got attendance sheet, you got consent signed, and so I have to give this RN standards of practice as well, because that's what we implement in everyday practice. So we work under registered nurse standard of practice, so I'm going to distribute those as well. You can distribute around, please. And so we have taken consent. I have given you attendance sheet. I have given you lesson plan, and I have given you pre-quiz. So if you can take a couple of minutes to finish the quiz, please, and then we start the session so that I know that what is your current knowledge, and when we will finish the whole course, then you will see that what you have learned from the whole session. Okay. Any questions so far? If you have any question, if you're not understanding about any quiz or anything, or if you have any question about consent, please feel free to ask. Okay, so we take a couple of minutes to do the quiz, and then we move on. And at the end of the session, I will also give another second quiz and evaluation form of the session, please, and feel free to give the comments on that evaluation form of the session, if you like it, or what you like and what you dislike, whether you need, if you have any further comments, you can put into that section in the evaluation form, which I will be giving at the end of the session. So first of all, thank you for joining this session, and so I'm sure that you will enjoy this whole session, and you will get information which in mental health we use in everyday practice. Is that okay? Or are you comfortable there?
Yeah. Yes.
Okay. So, as before we start, I just let you know that fire exit is when we go out on the right side, and at the end we turn right. That's fire exit, just in case if we need. Toilets are when we go out and then left. First toilets are female, and after the next door is male toilets. So, okay, so this whole session is about mental status examination, and before we start, anyone has any questions?
No.
Okay. So before we start, I acknowledge the country that I would like to acknowledge that the land we meet on today is the traditional land for the Ghana people, and we respect the spiritual relationship with their country. I also acknowledge the Ghana people as the traditional custodians of the Adelaide region, and their cultural and heritage beliefs are still as important to the living Ghana people today. So, session objectives are that what you will be learning at the end of the session. You should be able to safely and effectively assess the mental state examination, to maintain the therapeutic relationship with the patients, to provide person-centered approach, person-centered care to promote the recovery. There are intended learning outcomes for the session, so I have divided the whole session objectives into the learning outcomes. At the end of the session, you should be able to describe the rationale for doing the mental state examination, and you will be able to demonstrate the mental examination in a simulation setting. We will be doing a role play for 10 minutes where you will get real life experience. And you will be able to discuss in detail the mental status examination to develop a plan of care for recovery. So in mental health, that's very paramount. It's really important step for recovery for the patient, and patient-centered approach. So identify the common errors in assessing and documenting the mental status exam. Also, you will be identifying the barriers and challenges to assess the mental status examination, such as when patient disengage with the clinicians. So, any questions so far?
No.
If you have any questions, if you don't want to talk about here, you can send me an email at the end of the session, and I would be happy to answer your questions. So, what have you thought about we do in our daily practice, mental status exam? So why we do it? What's the rationale? Anyone would like to share? what's the rationale, why we do mental
Get an idea of their mental state and what they're thinking and feeling, and just to give us something to give to the doctors so they can assess and help assess.
Yeah, that's
the
really,
diagnosis.
really good. to
We're
share.
looking for a deterioration in their mental state, whether they're suicidal or
Yeah,
whether we need to inform the doctors any changes in behaviour,
yeah,
what they're
that's
thinking of.
a really good point. Anything else? anyone would like
Also
to
for the safety reason,
Yes,
so we can
Maintain
prevent.
the patient safety is
Yeah.
the really good one. But also when we do mental status exam, it gives us, give us data, provide us information about the patient. It helps to assess their diagnosis, it helps to assess their treatment, and also fast recovery for them. So it gives whole picture about the patient and helps in assessing the risk to keep them safe in daily practice, in a day-to-day basis, keep them safe, helps them to treatment, faster their recovery, helps them to diagnose their diagnosis, and helps them to provide further care when they go home. So mental status exam is really important, and it's give all kind of information about the patient, whether they are looking after them poorly, whether they are looking after them appropriately, whether they have self-neglect, whether they have any risk, whether they will be at risk of harming themselves or suicidal. It gives everything or whole idea about the patient. So therefore it's very important when we do mental status exam, we do it correctly. And also when we do mental status exams, there are some errors in documenting, and that we will be going through at the end of the session. So I'm just briefly giving this mental state examination about the patient, which is false name. Her name is Jasmine, and so situation is like she has anxiety, she has sleep disturbances, she has poor appetite, low mood, aggression, and also self-harm. So it gives sort of a situation that what's happening, and then when we do mental status examination, it tells about the current situation of the patient when they present to the setting, when they come to the inpatient setting. So it also denotes that what sort of situation they are in life. It says that they are at risk of self-harm, they are at risk of aggression, they have anxiety, so we can help them. So yeah, mental status exam has it made of a lot of components which we will be going through one by one. But before we start, anyone has any question? Any questions? Wants to talk about anything? Okay. So in appearance, what appearance? Like some of you are familiar with the appearance. So what sort of appearance tells us? What tells in mental state examination appearance means? Anyone would like to share?
How the person is look like,
Yep.
and how they walking, eating, like everything,
Mhm.
and how they maintain their hygiene level.
Yeah, and yeah, that's a good point. Also, it tells us that whether it's give a bit idea about whether they are, if we look at an appearance of a person, if it says to poor self-care, that means it could be like the person is depression. It could be the person has negative schizophrenia symptoms. It could be that person has some neurocognitive issues. So it gives an idea in appearance, like if the person level of hygiene is at appropriate, and if they wear reasonable clothes and everything. So that tells us that what their insight is, what sort of, it gives brief pictures, what sort of disease they have. So in appearance we usually talk about how how their clothes are, whether they're grooming or poor self-care, or whether they look steady days. If they look younger than their steady days, it could be their developmental delay. But if they say that they are older than their steady days, it could be that they are not looking after themselves. It could be that they're not treating their disease properly. They're not seeking any treatment. They're not seeking any help. So it gives us the whole picture in appearance. Then when we talk about behavior, so what sort of anyone would like to talk about? What's behavior mean? When we do mental status
Could
exam?
be just maybe they might be a bit aggressive or anxious, or maybe they're in an elevated mood or
Yeah.
panic mood, or
Yeah.
tells us a bit about how they're behaving.
Yeah. So yeah, that's really good. So behavior actually it denotes like what sort of issues going on, like whether they are agitated, whether they are aggressive, whether they have psychomotor retardation, whether they have bradykinesia, or whether they have psychomotor hyper kinesia or akathisia, or extrapyramidal side effects of medication, whether they have tics, whether they have abnormal involuntary movements such as oculogyric effect, whether they have catatonia, their body is so rigid, they cannot move around, whether they have acute dystonic reaction, whether they like sudden reaction from antipsychotics and their whole body gets rigid and they get oculogyric side effects of some medication. That's really dangerous. That can be life-threatening for a patient if we don't treat at that stage, because it imbalance all the dopamine and all the neurotransmitters in the brain and the body, and then it can be life-threatening for a patient. So it gives us what's the behavior tells us what the person's is going through, whether what care they need. If they have this acute dystonic reaction, we suddenly involve the team for their treatment. If they have psychomotor agitation, we involve the psychomotor. We need to treat the psychomotor agitation by one-to-one or by any kind of therapies, so that it won't trigger to the further stage where they can be secluded and risk for themselves and risk to others or risk to the property. So it gives every single step in mental status exam tells us what's going on with the patient and what's, as a clinicians, our duty of care to do at that stage. And then mood and effect. So mood also tells mood and effect. It's also really important, like appearance and behavior. Anyone wants to talk about what's the mood and effect mean? So mood is subjective data. When the person tells us, if you ask to someone, how are you, Mr. John, say for example, and Mr. John say, I'm good. So that's subjective data, they are telling to you, mood. But if effect is objective information we observe from the patient, they are saying good, and whether they looks good or whether they look sad and worried, whether that's congruent, whether they hiding information and they don't want to share information, and if they tell you their mood is happy, and in effect, if their mood is happy and in effect they shows like, if for example, if their mood is happy and they have something incident happen in the family which is not a pleasant thing, and they're still telling mood is happy, but effect is not congruent what they say. So mood is subjective information, effect is objective information, also gives an idea about the patient. And sometimes a person says, I'm fantastic, but they looks very flat and blunted, so that also tells that they are not well. Speech, when we talk about speech, not so much about content of speech, it's the production of the speech. So it's how they talk, whether they talking rapid speech, whether they talking too much, whether they are pressured, or whether they have like delay in speech. If they have delay in speech, that can be like they have something cognitive issue going on, or if they are rapid in speech, that could be with elevation in their presentation. It could be related to bipolar affective disorder, or it could be with elevation in towards that diagnosis. But if they say that if they don't talk about, they say I don't want to talk about, and they have latency, very latency in speech. That also tells us that person could be depressive. So it also gives kind of information, speech as well. And when we document their tone, their rate, their volume. No, it's not about the content actually. Okay. So that whole information together gives an idea about their psychological state, their mental state after completing the mental state exam. When we talk about thought, anyone would like to share what's thought denotes? What's paramount about thoughts?
You know, you're thinking self-harm or suicide ideation.
Yeah, that's
Just what they think.
that's
is
very important to keep them safe. When we talk about thought, we talk about thought process. We talk about thought content. In speech, we don't talk about their speech content, but when we talk about thought, we talk about their thought process, and we talk about their thought content. That's really important because thought process tells us whether they are tangential, whether they're talking. For example, tangential means when they go home, they start to talk about their daily. They talk about, I went home, I went to mother house, then I went to brother house, and then went. And your question was, what happened today? So they're not addressing the question, but they're talking about the different thing. So that's tangential. When we talk about thought process, circumstantial or circumferential, some people call it, they talk about everything. So your question was, how was it daily? They talk about, I went to mom, I went to brother, I went to sister, and then they come to you, yes, daily was well. So that tells you that their thought process is not linear, logical thinking. So their thought process is not like a normal, healthy person. So they can be tangential, they can be circumferential, they can be fixation, they thinking about just about anything in their life. It could be like snake, if we take an example. They just think about during conversation and come back and talk about the snake again. So they can be very paranoid. They can have delusions when we talk about content, and when they can have like suicidal ideation, self-harm thoughts, or harm to other thoughts. So in thought process, we document whether their thinking is linear logical thinking, or whether they are tangential or circumferential, or whether they are fixation, there is preoccupation. When we talk about thought content, we talk about suicidal ideation, paranoid ideation, their delusions, and their homicidal ideation, or deliberate self-harm or harm to others, all that contents. So this also gives us assessment to keep the patient, if they have any risk, to identify the risk. So perception, when we talk about perception, anyone wants to share? Any questions so far?
No.
If you feel like, especially who are not familiar with mental status exam, if you feel like any terminology you're not familiar with, please ask, and we can just change into the very simple language so that you can understand. So any questions so far? So when we talk about perception, what's that perception?
Just your senses and anything that's out of the realms of reality. I guess.
Yeah. So yeah, that's almost about perception, but also it's disruption of your perceptions. So when we talk about perception, the things the person can see who has mental illness could not be real thing for the other person, but the person who is experiencing them can be a real thing for them, and they get so involved sometime that they got these command hallucinations where they are driven by those perceptual disturbances. So when we talk about perception, we talk about hallucination, we talk about auditory hallucination where they hear the voices, we talk about visual hallucinations, they see the things. For example, someone might say snakes and they are so paranoid with it, they have very traumatic with that one. So, but the other person can't see it because that's not that real. That's their perceptions tell that's real. And sometimes they go in so much details that they start to get command from the hallucination, and they do what the hallucination wants them to do. If sometime, for example, hallucinations, auditory hallucination or visual hallucinations can tell them to cut their limbs or cut their arm or kill someone, and they will follow the command. So that's, therefore it's very important to document what they tell us and follow that up. And also sometimes they won't tell you because they are so paranoid, they are so traumatic, they have so much trauma and they have long history of mental illness. They might not disclose you some information. So how we can do it? We can observe and we can see that whether they're responding to any stimuli, unseen stimuli, or you can call it internal stimuli, which nobody can't see, but they know, they're responding, they're communicating. So that's, we also document in perception, in mental status examination about perception. Cognition function tells about the cognition of the patient, whether when they comes to hospital, whether they are alert, whether they know where they are, whether they know that the name of the place, the date and the time, tells about their cognition, whether they have, it could be due to their neurocognitive issues, or it could be due to their, for example, delirium, or it could be due to any other secondary to mental illness, any physical condition. So it's also important to document what sort of asking them questions. Mr. John, what do you think? What's day to day? Where you are? Can you tell me please where you are? And can you tell me what time is now? Or so that will give an idea about their cognition. When we talk about insight, what we talk about insight? Anyone would like to share?
How much knowledge they have about their illness.
Yeah, that's correct. Yeah, that's on the spot. So whether they have any understanding about their illness, can they identify that they have hallucinations, whether they are real or not? Can they tell you? If they can't tell you whether their hallucinations are real or not, then they have very poor insight. They don't know what's going on with them. And also if they know that they have schizophrenia and they're experiencing symptoms of schizophrenia, so if they tell you, that shows that they have good insight. So it gives an understanding about their illness and whether they want to get help or whether they want to reject help, about their care and treatment. Judgment. Anyone would like to talk about judgment? What we talk about?
Whether they are aware of their safety, they can make clear judgment in terms of their safety.
Yeah.
Yeah.
So judgment denotes that whether they have this decision-making capability. Can they make a decision about to improve their health? Can they make a decision that they need medication? Can they make a decision that keeping this knife with them is safe or not? Can they make a decision that going in the traffic and walking into the traffic without checking red lights, can they make all that sort of decision? Can they make decision that medication helping them? All that tells us about their judgment. And it's also can be judgment sometimes can be driven by perceptual disturbances, like they know that they have perceptual, they have hallucination, they are experiencing symptoms of schizophrenia, but they don't want to take medication because voice is telling them not to take medication. So sometimes that poor judgment can comes from the secondary to from symptoms. So therefore we have to look opportunity when they have less symptoms and given the medication at that time. For example, I know this patient who is experiencing for symptoms for a long time. She will never take medications from anyone, and for her entire admission wouldn't take medication. But one day when I was giving medications, I was going to her every day. But one day when she has less symptoms, when symptoms are not settled at that point of time, she took medications. She has OBS done, she took medications, she accepted everything, all the helps. But the other time she wouldn't take because the symptoms are so over on her mind that she can't make any judgment. She can't make any decision whether that's helping her or not. So that's all about judgment. And when we talk about rapport, what we talk about?
It's your relationship with the patient and
Yeah.
how much they open up to you and that sort of
Yeah,
thing.
yeah. So for better recovery of the patient, they, between a clinician and patient, there should be a rapport, which we call the relationship of trust. They should trust us for their care, that we are looking after them, we are there to keep them safe, and they should trust our care, and that trust build a relationship between us and patient, which we call it superficially established or established. We document in mental status exam. If the patient is trusting you and accepting all the helps and as compared to other staff, that means you have a good rapport with them. But if they are not trusting you and if they are not accepting help from you, but they are accepting help from the other staff, that means they have better rapport with that patient, and you don't have that better. It could be little things, asking water bottle, doing their OBS, doing anything for them. That all little things accumulate and make a big impact, which we call it rapport, good rapport, or established rapport, or superficially established rapport. Okay, and that all rapport helps accumulate and create a big impact, which we call it positivity, and helps their recovery, because they know that I'm at the right place and people are looking after me. And then when we talk about neurovegetative, what we talk about, anyone would like to share? Any questions so far?
It's regarding to their concentration, their sleep patterns, and their dietary habit, like while they are having food or not, how they eating, drinking, all those things.
Yeah, so if someone is sleeping for 2 hours, what that mean?
So they have a poor sleep pattern,
Yeah, and what that indicates?
like they have any problem or sleep apnea, like.
Yeah, that's really good point, but any other indication they
It
can?
might be
No,
better,
we could
it might,
manage.
or it might give us an indication.
Yeah.
They don't
So that could be related to their illness, because they are driven by hallucinations or perceptual disturbances or voices telling them not to sleep. So that could be from those secondary to like insomnia or lack of sleep, could be due to the hallucinations, so due to the voices telling them not to sleep. We had a patient where voices always tell him not to sleep, and he used to have like 2 or 3 hours sleep. So it also tells us how we need to treat the patient and what we need to do. It's give a whole picture. All neurovegetative again gives. If someone is not eating, they might be thinking their food is poison. If someone is not sleeping, it could be physically, but it also could be mentally as well. If someone has energy low, very low, they are all the tired, lethargic, they can't do anything, they just say I can't do anything, that means it could be indication of their depression. Or it could be malnutrition, or it could be other physical issues, they have medical conditions going on. So every single thing in mental status exams tell us what's that mean. It's not just for documentation. It's give about everything about the patient. When we talk about concentration, if they can't make any eye contact, if they cannot communicate with you more than 1 or 2 minutes, that means they have something, they are distracted, if you're talking to them, you are making eye contact, but they are looking somewhere, that tells that they are responding to something. So concentration also, we document poor or fair or limited, also tells about the patient mental state. We talk about weight. If someone has lost 6 kilo weight and in last 2 weeks, that also tells us about either they have medical condition, physical issues going on, or they are controlled by the voices or hallucinations, or they are not looking after themselves. So when we talk about risk assessment, so when we document into mental state risk assessment, we document static risk factor, which is in the past, what happened. And static doesn't change every day. So static is what pictures, whether they were aggressive in the past, whether they did suicide attempt, whether they have self-inflicted wound in the past, whether they, for example, harm themselves in the past or harm to others, or what sort of whether they were using drugs in the past or illicit substances. Just give a whole picture about the past. Okay, that doesn't change, static. So we document to get an idea about the person, so that we know more about the person. And so if something happens in the past, it's less likely will happen now, but it can happen. So we will be putting alerts on the seekers. We will be telling the staff and handing over the staff that the person last time, for example, put a knife on the staff neck. So that tells us to keep ourselves safe. And or if it was a patient, then we keep the other patients safe as well. So it keeps safety at the workplace. When we talk about dynamic risk factor, we talk about the psychotic symptoms every day. At particular point of time when you talked, you document what psychotic symptoms you observed at that time, what the risks looks like too, whether they are suicidal thoughts, whether they have self-harm thoughts, or whether they have thoughts to harm anyone. So it gives you dynamic risk factors, tells you what's today, what's now, when you talk to the person. Vulnerability will also give you idea whether the person is at risk to abuse or risk to themselves. It could be just simple as self-neglect due to their decline in mental state. They're not eating. They don't know what time is the lunch break. They don't know what time is they need to eat dinner. They don't know what time they need to eat breakfast. They don't know what time they need to sleep. They are so confused. So it tells the vulnerability of the person, that how much attention we need to pay them. Whether, and some in the ward you will see that some person are one-to-one special because of their vulnerability risk, and that's why therefore we put them on special who are at higher vulnerability, because that there is a safety issues can happen where the person, if it's related to their abuse, to avoid them, to keep them safe, it's better to escalate to the senior one and one-to-one special at that stage. And so hopelessness tells about the person. It could be more likely people with a depressive phase, in a depressive phase, will be very hopeless. So once they start to get energy and when they start to get treatment, then risk increase. So it's important to document their hopelessness, that whether they are thinking that they don't have anything in their life, there is no point of life, they are so tired, they are fed up with the world, and all that is very important to document. In daily risk assessment, we document their violence. So whole mental status exam, now we know that what sort of risk are they. That comes to the conclusion there. Whether they, from their appearance, behavior, speech, thought content, thought process, perceptual disturbances, insight, judgment, vulnerability, what risk is there today? Whether they are at risk of violence or aggression today, whether they are at risk of suicide or self-harm today, whether they are at risk of harm to other, or risk of absconding if they are involuntary patient, or whether their vulnerability increased or decreased. So that conclude us, and then if you feel like someone's self-harm risk was low yesterday but today is high, you will escalate to the team so that team can put efforts to keep the person safe. If someone has absconding risk low yesterday but today there was a fight in the family and absconding risk is high, you document, you hand over, you talk to the staff, you escalate to the senior team or team leader or doctors so that we can keep that person safe. Because if they abscond, they are involuntary, and if something goes wrong, then it's not a nice experience. So, okay, so any questions so far?
Yes.
Yeah.
So going back to perception,
Yeah.
why does command hallucination always have to be negative? So it's always,
yeah.
about hurting others, always about
Yeah.
not taking medication, not shower,
Yeah.
don't do this, don't do that. So
Yeah,
why is it
that's
always
very interesting
negative?
question, but not always command hallucinations are is negative.
okay.
Sometimes it can be positive as well. Like voices might tell them, command them, okay, you are the king of the world, or you are the celebrity or something else, and they start to behave like this. They will be walking when they walk and they talk, and they will it will reflect from their speech and thought and their mood and their conversation. It will reflect back to you whether they have negative command hallucinations or positive command hallucinations. Some people might have religious command hallucinations. They might be thinking welfare of the world. They might be behaving like they are God and they need to look after the people and all that. So, yeah.
So that can lead to someone being delusional
Yeah.
as well.
So delusions are more fixed thoughts, which comes under thought delusions, but under perceptions is mainly hallucinations, auditory, visual, tactile, gustatory, olfactory, all that hallucinations. I'm just keeping it as simple as it's too much to talk about. It might take 2-3 hours to complete the session, but I have to finish in time limit. So any questions so far? Any questions? Okay, let's quickly do one activity and then role play, and then we will going to finish the session. So I will be asking two nurses if they can come here. So if one can stay there. Here please. So this is to give you, this is a simulation setting, will give you an idea about the whole, if you can come here there please. So I just give you tell. Okay, if two nurses can come here please. The other nurse, yeah. Okay, so Yesi,
Yes.
so I want you to talk to Donna and try to engage with her.
Okay.
So
Hi,
can you
Donna.
do that for me if
Yeah.
you wanna come there?
Oh, yeah.
And if you can.
Hi Donna, how are you today? Did you have a good sleep?
She doesn't want to help you.
No? What happened?
Can't sleep.
You couldn't sleep? Was there something bothering you overnight or something?
She's trying to trick you.
Are you alright?
No.
She the one that spoke to you last night.
Yes.
Do you want anything?
No.
Do you want to have your breakfast?
No.
Alright. Can I just do your obs quickly?
Go away. Go away.
Alright. Okay, I'll come back later.
So can you see that?
Yeah.
That she is so involved with the voices that she can't concentrate what the nurse is talking to her, and so voices can be very traumatic experience for a person. It's not, I tell you, it's very, very traumatic experience for a person because they hear it all the time, 24 hours in their ears. And when we go and talk to them, we document our person refuse, but we don't know why they're not talking to you. So yeah, thank you for your. So this is the situation when if someone is not engaging with you, why they're not engaging with you, whether the voices are contributing in their concentration, and why the voices are telling them not to talk to you, where the voices are telling this person is going to give you poisonous food. So all that. So when any situation happen like that, please make sure that you tell yourself that this is not that person. I will come back and talk to this person again. Let the thing settle down. Or you try to do any pharmacotherapy or if there is any medications you can give to settle the voices, or if there is any plan by the doctor, or if you try multiple attempts to engage with the person, and then the person will tell you what was the issue. But this situation where the voices are at peak and they are distracted, she's distracted by voices, it's really hard to engage with that person. So when we talk about care plan, we talk about their sightings, we talk about monitor and assess regular mental state and physical health. We talk about counseling, we talk about that if someone has someone has a long history of depression, they might need psychotherapies, and we appropriately refer that person to the appropriate multidisciplinary team. We monitor their compliance and risk because that's the main part. Because if they are compliant with their treatment, then their risk will reduce. If they are not compliant with their treatment, their risk will increase. Therapeutic alliance promotes a person-centered holistic care. We talked about therapeutic relationship is really important. Therapeutic relationship with a person and their family, and to involve them into their care is very, very important. That way their recovery will be faster. And non-judgmental care, as we give a role play, we just played a role, that non-judgmental care, that we don't judge the people that, they're not engaging with us, so we don't need. Because they don't know what's going on with them, they are so distracted by the voices, so therefore we need to understand this and provide the care in a non-judgmental way and in a partnership. So we treating with a person and with a person-centered approach. Okay, any questions so far? Okay, it's a 1 minute video. If it's play, let me see, and it's quickly give you an idea. So no.
Adhere to the standards of professional. Nurses inspire confidence in their patients by treating them professionally, objectively, and ethically. Patients and their families expect nurses to always act in their best interests and to adhere to the standards of professional conduct while maintaining a respectful and professional relationship. But nurses have a type of authority and influence that comes from their professional position. Their specialized knowledge and skills, as well as access to private information, make the patient vulnerable. The inherent difference in this relationship requires boundaries to help nurses establish and maintain limits in their professional interactions with patients. By using professional judgment to determine and stay within appropriate boundaries, nurses can meet their patients' needs. On the other hand, nurses who put their personal needs ahead of their patients' needs will cross over these professional boundaries. These types of behavior violate laws and regulations that are designed to protect the public, as well as meet the standards of professional conduct.
So even though sometimes patients get so close to us and they trust us and they have very good rapport with us, we still
Mary, a home health nurse, has been providing care to Dorothy for more than 6 months. The two of them have enjoyed pleasant conversations, discovered several mutual interests. Dorothy genuinely likes Mary and is grateful.
Okay. So even though they trust us, we have very good rapport with them, but still we have duty of care to be in a professional relationship with them and not putting our needs more than their needs. We are there to look after them. So, and so that's about care plan. And when we go next slide. So also it's when they are recovering, when their insight is improving, when their judgment is improving, they are less risk, they are compliant, including them in social activities, encouraging them in gardening or volunteering or walk or whatever they like to do. That will reduce their risk and it will improve their recovery faster. Also, finding a GP where they can follow up their treatment after discharge from the hospital is really important, because some people, they don't have any regular GP. They will be going every month to a different GP. So educating them to have a GP where it can be for a long time also improve their recovery and keep them stable when they are in community. And involving their family is very important, because family is the main resource to provide us information and helps us to provide good care, quality care, person-centered care to the person. Also, it's very important if the person has any social issues, refer to the social worker. If they have any swallowing issues, or if they have food issues, or refer to the dietitians, or if they need any therapies, refer to the psychologist, or if they have functioning issues, if their functioning level is not good, referring to the occupational therapist. And if they identify as an Aboriginal and liaison from Aboriginal or Torres Islander background, liaise them, connect them with the Aboriginal liaison officer is very, very important, because cultural can be a very big factors in treatment and care and can be a barrier. So when we talk about common errors when using the MSc, when we document MS Metastate exam, when we talk about perceptual disturbances, we write responding to unseen stimuli, but what are they? I have seen few times responding to unseen stimuli, but what are they? What the voice is telling, we should go further beyond that point. We should asking them, okay, voice, they are responding, whether they're telling you about voices, whether they're telling you that voice is telling them something, whether they tell you that voice is telling them to harm themselves or others, or whether voice is telling them to kill themselves or someone else. So what the voice is telling, we need to go beyond that point. When we talk about thoughts, what we talk about, okay, future focused, but we don't talk about further. When we talk about
trying to discern groups, who we got on? No worries. Do you know who you have, Donna?
we will be finishing this one.
No worries.
Yeah.
Cheers.
Thank you. When we talk about barriers, so if, for example, Donna was there, she was distracted by the voices, she was not engaging. When disengagement happens, so that can be barriers to their care. So we need to identify if there are barriers or challenging, and find the right time and opportunities to break that barrier. Yeah? Okay. Just a very short video again.
Earthy is another example of a boundary violation. By allowing Dorothy to learn of her financial issues, Mary disclosed too much information about her personal life.
tests. I have
When she accepted a loan from her patient, Mary placed her personal gain ahead of her patient's best interests. Professional sexual misconduct.
And
This internet is not working properly, so let me try one more time. It's a very short video, just a few seconds. Oh, sorry, around a minute.
Welcome to a preview of Symptom Media's mental health nursing assessment tools. Did you know Symptom Media's collection of mental health nursing films covers a range of prevalent clinical cases and assessments? Be sure to visit symptommedia.com.
short period of time to stay here.
Well, I don't want
I have tests. I have a game coming up this weekend.
people are
What
more
do I tell my coach? What do I tell my friends? What are my parents gonna tell everybody?
my experience with schools is they're more understanding than you think they are. And they're
This is-
glad to know
this is
that
gonna
somebody's
ruin-
getting help.
This is gonna ruin everything that I've worked for all these years. Everything.
I promise to be there and help you through all of that.
These-
To be there, right there with you.
No, I can't. I cannot go to rehab or whatever this is. Whatever. I will. I will not go.
I'm gonna talk to your parents.
They're not gonna sign off. There's no way.
Be sure to visit symptommedia.com to sign up for a free trial today.
Okay. So you can see that what sort of barriers are there, because sometimes patient can be like thinking, what parents will be thinking, what my friends will be thinking. I don't want to get admitted in the hospital. So it's not just an illness; it's also psychological
Stigmatization.
stigma as well. Okay, so summary. What we have covered in the session again is all here. So we talked about rational, we talked about demonstration mental status exam with a person-centered approach. We talked about how we can develop a plan of care for the recovery. We talked about common errors and barriers and challenges in mental status exam. And any questions? Any questions? Thank you for consenting and thank you for pre-quiz. Just a very short quiz. Again for part 2, if you can distribute that please. If you can complete this quiz and some handouts for you for further aids at home. And I would encourage you, if you can do a reflection in your diary, that will help to remember everything. So doing reflection in the diary about whole session today will help you to remember everything and how you can implement this learning in your clinical practice is also a good idea. Did I give evaluation form to you? Yeah, so if you can please complete that. There you go. This evaluation form, please. Yeah. Thank you. There you go. Evaluation form, please, if you can do that. There you go. So thank you for again for consenting, for joining and participating in this session. If you have any question, feel free to email me please. And my email address is emailrkd@yahoo.com. If you need, you can write it down and you can email me. And if you can just complete that evaluation form please, that would be great. Thank you so much. Here you go, pen.